I liken it a bit to people ask, when am I ready? Because we're always looking for new sites for our students. And people are like, well, I don't know if I'm ready to take on a student. And get someone to becoming a parent. You're never fully ready, but at some point, if you're generally prepared, you're generally going to be fine.
We all want to help people and we tend to give away the answers, but that doesn't allow us to actually figure out how they're thinking clinically. And that's our whole job. There is no way for any of us to teach the breadth of medicine or pharmacy. Our job is to teach people how to think clinically so that they can apply that information across their career.
On today's episode, listen in as our expert panelists discuss tips for creating successful learning experiences for students and residents. We'll review various teaching tools and summarize strategies for incorporating learners into your practice. We'll also discuss different approaches for providing meaningful feedback and managing challenging situations with learners. Our panel for this conversation includes Dr. Andrea Darby Stewart from the University of Arizona College of Medicine, Phoenix, Mary Franks from Bradley University and Carle Health, Dr. Megan Smith from the University of Arkansas for Medical Sciences, and Dr. Craig Williams from the Oregon Health and Science University.
And now, the CE information.
This podcast offers continuing education credit for pharmacists, physicians, and nurses. None of the speakers have anything to disclose.
So to kick off today's discussion and give us some background, I'm going to have the panelists briefly share their role as a preceptor. And Andrea, I was hoping you can start and let us know how long you've been precepting, your practice setting, and what your current interactions are with students, residents, and any other learners you may encounter.
Thanks so much, Sarah. Absolutely. So I've had the privilege of teaching in graduate medical education as well as undergraduate medical education for the last 24 years. I'm a family physician by training and have served as clinical faculty, associate program director, and even worn the mantle of program director at 2 different programs. I currently precept our residents in the family medicine residency program in both the ambulatory and the inpatient settings. And I have a lot of fun, particularly with our first year medical students from the University of Arizona during their continuity clinic experience.
Wonderful. And Mary?
So I am an adjunct faculty professor for Bradley University. So while I also precept students, I also help them on the Bradley side as well with their FNP program. I particularly work my urgent care practice, PRN. So the majority of the students I have are the FNP program. I usually get the students towards their 5th and final semester.
Perfect. Megan?
What I do at the UAMS, University of Arkansas for Medical Sciences, as a full-time faculty position, I've precepted APPE students in different levels of learners for about 10 years. And since I've been here at UAMS, I've developed a APPE elective as well as precepting direct patient care in the community's pharmacy settings. And then for the past 7 years, I've been a residency program director for our PGY1 community-based residency, where we host up to 7 residents. And so I oversee their experiences and progression. And then I have a new role where I'll be directing community advanced pharmacy practice experiences for the whole college and helping with preceptor development over the next few years. And so that role just started. So I'm really excited and happy to be here today.
Awesome. Thank you for joining us. And Craig?
I've been doing this almost exactly as long as Andrea has. So I'm a mid-90s graduate and then went straight into residency and then academia. And I've been now more hospital focused for the last 10 plus years, but first part of my life was in an ambulatory setting. And so experience mostly with family medicine and medicine residents. And then the pharmacy side, both the senior 4th year students and their advanced practice clerkships, and then anywhere from 1st through 3rd year on their introductory clerkship experiences. And in the last 7 or 8 years, we're seeing a lot more of the junior medical students with us at the hospital as well. So a broad swath, going on 3 decades of doing this.
Well, great. Thank you so much for all that background, everyone. I love how we have a little bit of everything. So that is great. I think that's going to be really helpful as we move on to how you prepare for students and how you kick off an experiential experience. What type of advice do you have to help prepare people who might be having their first student or resident on a rotation or experiential experience? And I will ask you, Megan, to answer that first.
Thank you so much. And you may see a key theme from my answers and things that really motivated me over the last few years in increasing the number of learners that I take on experiences with me, which is to involve our students in practice transformation, or you may know of it as practice advancement activities, or anything that the way I describe it to preceptors is, what is that thing on the back burner that you haven't gotten to yet because you don't have time? What are those activities, or what are those ways that you're wanting to improve the practice as a whole or your specific practice? And let those students be a of a real problem and develop like a plan and a solution with you, with your guidance. I think that's just as what I've learned over the last few years, what I've grown is, as important it is, of course, for us to teach them and to impart some of our wisdom, it's just as important and should also be improving our practice too. And we're really seeing that a lot of opportunities in the community-based settings because we're doing things we've historically haven't done, like test and treat, prescribing, doing a lot of assessments, doing a lot more collaborative work. And so there's new ground to be broken, and it's very dual benefit for you and your practice and for the student to get them involved in solving those problems as well. So how I prepare for students, and I go through this process every month. I promise you, every month I have to pre-plan and identify what is the nugget, what's that little project that they're going to help me with to get me from point A to point B. It might not be launching a full service like point of care testing from the ground up, but it might just help me with that overall goal. What is just something, one step to get me closer to that? I might target other pharmacies. So I do an elective as well as direct patient care myself. And so if they're on my elective, I'm actually serving multiple pharmacies. And so we look towards what's something going on that's relevant in practice that another pharmacy is really trying to get off the ground, and we target those. So with that, I'm trying to really think of what's relevant, what's something really interesting and unique that a student can help learn from, but also contribute to. And with that, I'll create a syllabus with defining that project, defining who their contact is, outlining the specific, like what my expectations are and outcomes, and with a specific calendar so they know where to be and where to go. And sometimes my syllabi are kind of bare bones and they're scared on the first day. This is where you need to be and what you're doing, and all the background time to look at all the background resources. I might not know exactly what the answers are either. We're in this together, and I'll be with you every step of the way. So those are just a few of the things I do that to make sure that every rotation is special and unique and provides a whole experience for them.
That's great. Thank you for sharing. Andrea, would you mind offering what you do to prepare for your students and residents?
That's a great question, Sarah. And I kind of, so it's funny, I kind of chuckled as I listened to this. And I think Craig might have been in the same position as I was, because having done this for nearly a quarter of a century, I don't necessarily feel as if I prepare my explicit teaching more than I think about ways that the specific learners that I'm going to be working with will best engage in whatever
Mhm.
setting they're in. So, I have the privilege of working with a large number of faculty members who have great insight into our learners as well. So if I'm going on the hospital service, one of the things that I'll do to prepare for that process is learn a little bit about how the last week went with this team and where I can help bolster their confidence, increase their learning, where are the bright spots that we need to let them really shine with, and where are the weak spots that we need to help them bolster up so that they're able to provide the best patient care in a safe manner. With respect to preparing for more junior learners, in my case, this would be the LCME or the undergraduate learners. It really depends on their level of training. And my preparation for those learners in a direct teaching setting, either in the clinic or the hospital, is really to assess where they are and ask them to do a self-assessment. What can I best help you with? Because I don't have as much insight into their background. I don't have that information from colleagues about, you know, this third year medical student who's coming to me from their OB rotation had these challenges. I really have to rely on them to provide me with that a moment of self-reflection so that I can meet them where they are and then provide the most effective learning opportunity for them at that moment.
That's a great take on that. And I think some really good strategies there. It's lovely when you have that continuity. We don't always get that lucky in pharmacy. Craig, do you have anything else to offer?
To dovetail onto that, it's interesting because I do some didactic teaching of our students earlier, of our pharmacy students earlier in the program before I get them on their advanced experiential clerkship experiences. So I often have a good sense of kind of who they are coming in. And it's interesting, when I work with the medical residents, I don't have that luxury at all. And then often they're coming from other programs across the country, and it does change it a bit. And I'd echo Andrew's sentiments. When you can learn something about kind of that student that's coming to you, it does help. At the same time, having done this now for over a couple decades, this is, precepting is a muscle that gets a lot stronger as you exercise it. And you do get to the point where it keeps me a little more on my toes to not know what the skill set is of the learner coming to me. So our interns are coming to us soon at the hospital, and that's always an interesting pool of learners to get on the surface. But I still think becoming a medical intern is the biggest kind of transition in the precepting world that we experience from a pharmacy or medical school standpoint. And there, I'd say the big lesson there is to be a preceptor, as long as you have some time and interest to give to it, you're generally going to be fine. So you do have to, though, recognize that it's going to change your workday a bit and your workflow a bit. And so you can't have a busy 12-hour, no time in the day set up for yourself and take on a learner. So, but I think if you have a bit of time and the interest to give to it, you'd be surprised kind of how well you can do. So I liken it a bit to people ask, when am I ready? Because we're always looking for new sites for our students. And people are like, well, I don't know if I'm ready to take on a student. And get someone to becoming a parent. You're never fully ready, but at some point, if you're generally prepared, you're generally going to be fine. So I'd say, prepare, but don't over prepare. And it's great if you can know something about the student coming to you, but don't feel like you have to know that much. If you have the time and a site that has good experiences, I think you're generally going to be fine.
Mary, I would be curious about your take with your busy practice. What strategies do you use to engage them?
I have not been doing this nearly as long as Andrea and Craig. I've been a nurse practitioner since 2019, and I took my first student right in the middle of COVID. So early 21 is when I took my first student. And that was a whole different world, right? Because at that time, I was specifically working as a provider in the skilled nursing facilities, and I'm still trying to learn my role myself to an extent. But then we're also trying to learn the whole telehealth realm of things too. So that was kind of interesting to have a student come in with me for that, because the student actually was very local to me. So they came to my house in my home office, and we were able to teach some telehealth points to the student, but also be able to have that experience of still seeing patients virtually. As far as the busy urgent care, that in itself kind of honestly depends on the day. And I would echo Craig's point. Urgent care is a different beast in itself, and you never know what your day is going to be like. Some days I'll have 20 patients in a 12-hour shift when I work a 12-hour shift. Other times I'll have 40 or 50. And you really have to have that desire and that passion to teach those students that are coming with you, because like Craig said, if you don't have that drive and that passion and that desire to provide those experiences to that student, and you're just a very type A kind of go do it yourself kind of thing, they're not going to learn. And a hands-on approach a lot of times in the urgent care setting is something a lot of students need and strive for.
Thank you for sharing that. I think that's a great introduction to getting started with students and residents. So This is a good transition to how we can tailor the learning experience for each individual. Because as you know, sometimes what works for one learner doesn't work for the next. And so, Craig, what teaching tools other than wisdom with age, um, have you found successful when you're teaching learners?
I'm not sure there's any one tool I have other than to kind of go back to the earlier point. You do have to do some preparation. So if you have a mature, good clinical site, and again, you're ready to give the energy to the process, then you do need to having a syllabus prepared and something to send the students so they kind of know what to expect. And then sometime early on, if you learn something about who's coming to you, that certainly helps. And so like for all of our pharmacy students, they have to email preceptors ahead of time and tell them what they've been doing in the year so far, what experiences they had, kind of what their goals are for the rotation. But before we started doing that, I think all of our good preceptors would sit down with that student and just have that open discussion of where
Mhm.
they want to be years down the road, what they want to get out of this particular 4-week or 6-week experience. And then pretty early on, you do learn, is this a student who kind of is pretty advanced, even when I don't know anything about the learner coming to me? Pretty quick in the first day, you get a good sense of kind of where the student's at and what they're going to need to bring them forward. And then it is about kind of tailoring to that individual learner. So, but
Mhm.
beyond a not too detailed syllabus that I give and a little bit of email work before they show up, a lot of that, the tools in the first week is really connecting with that individual learner and getting a sense of where do I think they're at now and how do I move them from their point A to their point B. It is a little bit of just jump in and trust that it's going to work pretty well. And again, that you do strengthen that muscle pretty quickly as you work with learners.
Mhm. That's a good point. Is just practice.
It doesn't make perfect, but it makes a lot better. Yeah.
Yes, for sure. You definitely learn with each learner that you have on rotation, so that's good. Andrea, is there any specific method you use that you found successful with your learners?
Yeah, I think that's another great question. And I would think about it in the context of, as an experienced preceptor, I think that we just naturally flex into different types of tools or teaching methods. In our program, we encourage our residents to act as educators, the senior residents to the junior residents and medical students. And
Mhm.
then I've mentored many new faculty as well. And the two techniques that I think are helpful for them that can set a pretty simple stage are to figure out where your learner is. And so in the osteopathic and allopathic medical world, we would think about the learner levels according to what's called RIME or RIME. And R stands for reporter. I is interpreter, M is manager, and E is expert. And the reason that I bring this up is that particularly many brand new preceptors think that suddenly magically you've graduated from medical school and you must be able to do a pretty good differential diagnosis and come up with a management plan. And the reality is that if a learner has not yet learned how to accurately report the first R in this rhyme mnemonic, then they can't interpret effectively the information that they're reporting to you, be that historical information or diagnostic information or social information. And if you can't report and interpret effectively, you can't manage, which means that you can't create that differential diagnosis and come up with that basic management plan.
Mhm.
And so, one of the first things that I try and assess with both the medical students and the residents is where are they in this spectrum? And I encourage our junior faculty and our residents to do that as well, because then they get a little less frustrated when a learner isn't at the level that they expected, and they can teach to the level that they're at and meet that learner where they are. And then we do teach our learners how to use the 1 minute preceptor, which is if somebody is presenting to you, get a commitment from that learner about what they think is going on. And that's a hugely important step. We all want to help people and we tend to give away the answers, but that doesn't allow us to actually figure out how they're thinking clinically. And that's our whole job. There is no way for any of us to teach the breadth of medicine or pharmacy. Our job is to teach people how to think clinically so that they can apply that information across their career. So you get a commitment. You try and figure out how they figured out what the supporting evidence for that commitment was. Where their patient has a viral respiratory illness and they have a supporting evidence of this duration of illness, a cough, runny nose, itchy eyes. Once they're done with their presentation, let them know, hey, this was great. I appreciate the way you structured that information. I can see the patient in my head, whatever that reinforce of positive that was done well. And then talk a little bit about the errors that they may have made in that clinical reasoning, if there were any, or any omissions that you would want them to bring to light in the future so that they can be more broad in that differential or that management plan. And then just come up with a general principle. Patients who have upper respiratory tract infections will typically get better after 7 to 10 days, and they do not need azithromycin and a Medrol dose pack. And then ask them if they can summarize that back to you as almost a teach back method as well, so that you can get clarity from them if they have questions. So those are the two things that I try and teach both new faculty as well as our residents as educators.
That's great. And the 1 minute preceptor is just one of the many tools out there. Megan, do you have any tools that you have found that have been successful for you?
Oftentimes, I'm getting a student, for example, on a community rotation who has already given a lot of vaccinations and immunizations throughout their learning experiences, either before a previous rotation or just previously in their curriculum. If I get them the first time on my rotation, I'll say, okay, I know you've done a lot of these, but you have not done one with me. So you're going to watch me first and what I do, and then we're going to talk about it, and then you're going to watch you do one, and we're going to talk about it. So I kind of set that up right away up front, and I have them comment on what they saw and picked up on me and what I was doing in my encounter with the patient, kind of have them analyze that even as a starting point to discuss some of those pearls. And then when it's ready for them to do it, we'll of course give feedback on how they performed as well. And that is just sort of my go-to is the instruction modeling. I'm coaching you, and then you're out to facilitation.
Thank you for sharing that. And I think another thing that's different with each learner is different learning styles. Can you comment on how you kind of adapt activities to different learning styles?
I don't try to just go to one specific learning style. I think we also tend to teach that way too. It's just a way to bring input in, and then a learner has to sort and process that information, correct? So what I like to do is have just a variety of materials. We start with that whole preparation and background. I give them materials to read, to prep them, guidelines to look at, things that we're going to be talking about a lot on our rotation. So they have the physical, they can visualize that and input in that sense. And then I do a lot of topic discussions, and we will, okay, what just happened here and the why. A lot of times I'm not even pre-prepping some of those topics. It's just something happened or occurred, or a new question was thrown our way, or a new patient encounter was thrown our way. And I have to, well, of course, take care of the patient if that's the case, but then I'll stop and say, why? Why is that? How does it relate to everything else we've done on this rotation? Why is it important how the financial model works? Why is it important how this patient got here, and what can we do for them next and with continuity of care? So I try to just keep it as a whole, using all of them, all of those inputs. So if they needed input to read it and write it, they have that. If they need an input of doing it and being with me, they have that as well.
Awesome. It's good to provide them with everything, and then they'll figure out what works for them. I'm going to move us along to talk about some of these other big questions that are coming in from the audience. We had another question about incorporating learners into your practice. So, Craig, how do you get accomplished your day-to-day tasks, having the student or resident help out, but yet still fostering that learning environment?
It's a good question. I think go back to the 4 preceptors role is a good example of where, for someone who's very new to precepting, that is the great way to just think about and to model it. Once you've been doing it for a while, it does become a little bit more embedded, and just kind of it's just the way you kind of do it. For almost every learner who comes to you, there does need to be some modeling early on. And so it's interesting, our pharmacy program is 4 years, and then the family medicine residency program I work with is 4 years. So I get to meet our pharmacy students in their first P1 year, and then see them again in their 4th year. And it's quite a transformation. I get to see our family medicine residents as interns in their first year, and then again in the 4th year. And there's just, it is such a difference. So the way I would handle a first year pharmacy student, or if I miss an intern, and the discussion we have is different than what you do for a fourth year medical resident or for a senior pharmacy student. So I'm directly precepting senior pharmacy students. And I think you need to structure your day such that, at least early on in their experience, you are kind of going about your work and they are seeing what you do. So we have 6-week rotations, and I just kind of tell them the first week is, for the most part, you're going to be orienting and learning and kind of watching. And then we kind of move you along during the 6 week. I think just being realistic and kind of doing that modeling early on that we've talked about, and then gauging where your learner is at, and then moving them along their curve as quickly as you can. It is about having your workday set such that at least early on they can watch what you're doing and then kind of move towards modeling. And then you can let them go on their own a bit, but still be around and able to kind of be that kind of preceptor from afar and watch them progress. So it really is kind of the operationalization of that 4 preceptor role model, just in the real world practice setting.
Mhm. Mary, I have a question from the audience for you that kind of ties into we just think that we're always busy. Everybody's busy. But this question is, how do you keep students or residents engaged and involved if your clinical side is not as busy as others may be? You had mentioned earlier, some days you'll have a lot of patients in urgent care, other days you will not. And so how do you engage students on those slower days?
That's actually a great question because I am a lifelong learner. So if I have downtime myself, I will look up something that I haven't seen in a while, or something that I'm not quite as comfortable with that someone else has seen in the clinic within the past couple of days or weeks. A few of the clinics I work at do have primary care providers in them as well. If I have a slower day and I have a student with me, I always talk to that provider that I'm working with that day and just say, hey, if you have something interesting, let me know. Or if you've got a patient that seems like they would be a really good case for the student to sit in on with you, let me know so we can kind of get them a little different look on how you may practice as well, or what you might do in a different situation than myself.
That's awesome. Thank you for sharing. I'm going to move us along. Let's talk a little bit about feedback, because I think this is always where folks feel uncomfortable. Megan, what are some tips that you have, methods that you use to provide feedback to your learners?
Well, I am a big fan of the stop, start, and continue method, and that's really effective for written feedback, especially. I found the most positive experiences with that when I'm having to write out what they need to stop, start, or continue. So that method is commenting on things that you want the learner to continue doing, behaviors you want them to stop, or behaviors or actions you want them to start. You're commenting on those really objective qualities. The other thing that makes a good feedback session is being objective as possible and giving a qualifier to it. Are they doing it appropriately? I like to use adverbs. Are they doing it appropriately, consistently? And then any feedback, don't leave them hanging. Make sure you know, like, what should they do to get better. So I love the start, stop, and continue when I'm kind of assessing an overall large learning experience or multiple encounters, or kind of how are they doing, over the course of a week, let's say. But if I'm giving feedback at a specific clinical encounter that has happened, I like to comment on everything. I just go through the whole encounter. I'm not just highlighting, oh, you did great, you did great, you did great. Comment on everything, and you're not just picking out the great things or just focusing on the negative things. I go through, for the example of maybe giving immunizations, it's okay, when you started, you established good rapport with the person. I saw you do this. I saw that you asked appropriate questions. And then, at this step, you could have done X, Y, and Z, or what else did we miss? And we would go through the entire encounter A to Z. So for my nervous students, ask them how they think they did. And I think that's very valuable. But if I can tell it's my first time with them and they're anxious, I kind of let the wind out of their sails, like, overall is okay. all right, let's get into specific feedback so I can teach you something. And they're like, oh, okay. So they're not kind of waiting, going, did I do okay? Or did I completely miss something? And so I think asking them, though, how they feel, how confident are they with their performance, as you get into those details and going step by step, can help validate what they're feeling, can help if that was a intended choice that they made or not. So those are just a few tips about getting feedback that I've used.
Excellent. Craig, what do you have to add to that?
Yeah, I always start with how do you think it's going or how's it going from your standpoint? Learners often have a really good idea how the experience is going, and they know a lot more about kind of what's going on in their head than I know about what's going on in their head. So whether or not they think they're nailing it or they think they're really struggling, and their perception's often not exactly, we're often close, but it's often not the same. So I don't know if that's officially the ask tell ask system, but I always start with that before I give them my formal feedback. If your formal assessment's at end of week 1 or end of week 3, they shouldn't be surprised by what you're going to say because it really should be an ongoing kind of dialogue with that learner. There's many touch points during the day and even many touch points in typical hour in the hospital setting to kind of give some constructive feedback. So it's not just modeling what you want them to do, but then gently pointing them towards things they did well and away from things that they didn't do well. So again, it shouldn't just be one formal time, but when you do that formal one and there's not a bunch of other people around, ask your learner how they think it's going because you do learn a lot from their perception.
Mhm. Yes, that's great. And then I think, Andrea, can you comment too about how your feedback process is?
Yeah, I think it's really dependent on the learner and again, what level that they're at. If I'm working with somebody with significant deficits that we've identified previously, and there is a significant focus on a particular area in graduate medical education, we refer to milestones and core competencies, then that may be the subject of my feedback. As Craig alluded to, I think the best way to start this session with learners of any level are to say, tell me a little bit about how you thought that session or that week, in the case of my inpatient service, went for you. And what were your bright spots or your areas for growth that you identified over the last week? And we've set the stage for this because at the beginning of the week, I've asked them what are the things that they think they're doing well and what are they really working on. So we've been able to kind of go through that over the course of a week together on our hospital service. I'll then validate or correct the statements. And I think for the most part, people are fairly self-aware. We do have, we all have some learners and individuals in our lives who definitely have some blind spots. Part of our job as educators is to help them understand those areas that are good areas for growth, as well as the things that they should continue doing. I always end these sessions with a question to them about what I could potentially do differently for them in the future, or what should I continue to do that was effective that will help them advance in their education. I like to close with that as well because I think that they deserve the opportunity to provide us with feedback. That's a
Mhm.
mature adult thing to do, and we are trying to teach them how to be professionals in a world where we would hope that we would have strong professional relationships with all of our colleagues in the future.
And I'll just say, if you don't, for someone who's maybe doesn't want to hear something constructive from their learning, you always ask, like, what can we do different about the experience? Because just
Mhm.
the workflow of the day. I mean, for us, sometimes it's as simple as like, how do they get in the med center in the morning and what time they need to be there and just how's that work? So it doesn't have to be necessarily just about you as the teacher, but it'd be about just what can we do different about the experience to help you for the last week or the last 2 weeks or whatever it is.
I ask, what can I change about your schedule, the rotation? Should we prioritize anything else new for the next 2 weeks? So I love it.
That is awesome. Great. Thank you guys so much. I think we'll move along now to managing challenging situations. We have a lot of questions coming in about managing student burnout. How do we help them with time management? So, what are some of the biggest challenges that you face with learners, Megan, and how do you go about handling them? Maybe just pick one. We'll have you each pick one to talk about.
Okay. I've had some instances in the past of an overly confident person. The overly confident, though, one around, I know what this is. I've been in the community pharmacy a long time. I'm at the very end of my education experience, ready to take the boards and be done. So, for those particular learners, I'll still try to find something. I think making that commitment decision, that 1 minute preceptor, works really well. And then I've had to sit down with one person and say, okay, this didn't go well, and being very specific of this drug, you did not know the indication for this medication. Tell me about that. We need to set time aside for you to study for your boards if that is the case. These are things that are expected for you to know at this point, because I think we all might be able to point to areas of improvement for those that are overly confident. They just don't see it, and being as explicit as possible. I loved, I think, how Andrea said earlier that this is our job. Remember, it's our job to give feedback, even the things that are saying this is not up to par, or the way that you have interacted with me and this email being late, being these things and pointing them out. They might not have been told that before, and you might be the only thing between them and their future employer. So take that to heart as well, that it's okay to give hard feedback as well, and working through some of those challenges if they do have a learning deficit or almost overconfidence or unprofessionalism that it might present as. Happy to hear other thoughts. There's a lot of these, and I think Craig did really well in the beginning of, you just see a lot of them, you get more comfortable as the more experience you get.
I'll kind of echo one thing Megan said of it. I often tell my students, I'd rather have you be less confident than overconfident coming into a APPE. So, the way most pharmacy curriculum structure, they don't really get to do a lot until that APPE year. It's kind of like their medical intern year in the medical residency world. I always tell them, you're allowed to guess on tests, you can't guess in practice. So I think the biggest challenge I have is for the student who just seems to be able to not form the hardest answer of all, which is, I don't know. We have a lot of students who just don't seem to be able just kind of say, I do not know. And like we tell them, like, we're putting you with preceptors that you're there to learn from them. But particularly our students who are kind of in the upper tertile of the GPA, they don't want you to know what they don't know. So they'll just kind of start giving you lots of answers, and they just will not, 5 minutes later, you're like, I'm looking for one simple answer and you haven't gotten there yet because you're giving me every guess you remember from your classes. So a challenge for us is just getting students to admit there's a lot of things you don't know, and that's okay. You're still a learner, even though you're within like maybe 2 months of graduating, and it's okay to say, I don't know, and then use the experts around you to become a better pharmacist, physician, whatever track you're on.
Excellent. Mary, do you have any comments?
One student I had most recently, I had been with her probably about 7 weeks of the 15 weeks she was going to be with me. The student came out of a room one day and was like, this person's totally faking it. And I kind of snapped my head real quick and was like, what did you just say? And she's like, they're just faking it. And so she gave me a very brief, history of what was going on. And she's like, but we're not going to do anything because they're faking it. What it came down to is I did have to be kind of that firm speaking person that I really don't like to be, and say, we don't come out of a room and just instantly say someone's faking it. You have to have a professional attitude about every patient that comes in. You really need to have a professional attitude with me or any other preceptor that you encounter, because what you may think someone is faking, there could be something seriously wrong with this person. And truth be told, they did have a serious issue, and we ended up sending that patient to the emergency room, and they had surgery later that night. So when I filled the student in the next day when she was with me on what happened, I just said, how do you think things went the other day? I feel like, me personally, we kind of had a bad setting that day. And she's like, well, I just felt that they were faking it, so I thought you should know. So I kind of told them, what went on with that patient, and that really changed her attitude with me that day. From what I gathered, I try to be the most positive person I can when I'm around my students, even if I'm having a really busy, stressful day, or I'm getting behind on charts and things like that. But bringing that positive attitude and that positive energy to that student is really going to help them portray themselves too, even when they're in a room with a patient. Because if they go in with the attitude of, oh, they're faking it with a patient, they're going to miss differentials that are going to be significantly important.
Thank you for sharing that. Yes, having those hard conversations. Andrea, do you have anything to offer? And I would be very interested in some of your tips that you have for residents on time management.
Set a clock. And I kind of say that a little tongue in cheek, but really and truly, time management is about being able to set an agenda in a compassionate way, set your own personal boundaries with patients, reassuring them, particularly in the context of being a family physician, a continuous comprehensive care clinician, that you will eventually get to all of their concerns. It just may not happen in your 20 or 40-minute visit. And really enlist the aid of the people around you, the MAs and colleagues that can help you with that gentle knock on the door and kind of moving that visit along. Patients have no idea how long their visits are. And when a kind person sits down in front of them and engages them in a compassionate conversation, they are very happy to tell you everything that they think you need to hear. And so learning that skill of being able to put some boundaries on your time is just really important and effective for my learners.
Excellent. I have one other question coming in about how do you precept that high performing learner that actually gets it and continues to just push you?
Oh gosh, those are fun. Um, uh, Set up new projects. Oh, that's a great
Yes.
question. Why don't you come back and tell me about that? You know what? I would love to have you. I think that's a terrific observation about the multiple causes of hypercalcemia. It's a great teaching point that you might be able to bring to our next ResVac meeting. There's so many ways to help engage a learner in that area. And in our practice, as I'm assuming in all of my colleagues' practice on the team, we've got plenty of opportunities for quality improvement, patient safety, patient experience. And so engaging them at a higher level than just this patient has this condition and I'm going to treat it with this intervention. If we can engage them across a higher level at a systems level, that sometimes will satiate their appetite for new learning.
Excellent. Thank you. And I do want to have you each share one piece of advice with our listeners to help them improve their effectiveness as a preceptor. We talked about a lot of tips, but I guess I want you to reflect on your journey and what is one of those pieces of advice that you really think was impactful and changed the way you precept that might help some of our listeners. I will start with you, Megan.
I think that Mary's Pearl and the example that she just showed is a good example that you're there to teach them clinically and they need that experience for sure, but you are also there to teach them how to be a professional and their professional identity. So involve them in those things that maybe there's projects or patient cases or things that are just not yet realized, and help them see how you solve that. How do you handle a challenging situation? How do you handle professionalism in your setting, or how do you advocate for your profession both in small and big ways? So I think that's what I leave as my one advice. But also with my new role in experiential education, I really wanted to put in a plug that if you have a challenging learner, to also make sure you check and lean on and report to and use folks that are in experiential education or equivalent. They will have policies on how to deal with that, and make sure it is reported, because you might be the last stop, or you might be, the fourth time that someone, and it's like four times and there's red flags and there's other things happening and they're just waiting for you to bring it up. So make sure that you engage with them and let them know, because those overseeing departments and colleges or educational programs really need to hear the input from everybody and what is going on with that student or that resident.
Thank you. That is a very good point. I think many of us have had to do that. Craig, what are your thoughts? What are your
Yeah,
final thoughts?
I'll say, once you are comfortable in your practice setting, you really are ready for a learner. So if you have a setting that would just be a good exposure for, again, first year medical resident, a medical student, pharmacy student, then you're ready. So back to my analogy of it's like trying to be preparing to be a parent, you can only do so much. So once your kind of sight is kind of mature and you're comfortable in it, then I'd say my advice to that person would be do something to prepare, but don't over prepare. So I liken it to when our students give their oral presentation, I can tell when someone's tried to memorize every line of every slide they want to say, and they inevitably fail along the way because they were so over prepared and built it up so much in their minds that if it doesn't go perfect, it's like a disaster to them. And that's not the way to prepare. Just kind of be comfortable in your practice setting, and then just be ready for every day is going to be different with your learner. But again, if you're comfortable in your setting, you really are ready. And it'll be a great experience for them. You may not think it was a perfect day from your standpoint, but if you remember back to like 5, 10, 30 years ago, when you were a student, it's like a good exposure to a practice setting is just hugely rewarding for students who have been in the classroom setting for a lot of years. So it doesn't need to be perfect, and it's going to be good for the learner.
Awesome. Andrea, do you have any quick tips in 30 seconds or less?
I'd just say model the professionalism that you want
Oh,
to
excellent.
see across clinical competency, compassionate communication, and lifelong learning, because each learner you touch will have a ripple effect
Mhm.
over years. So you're not just seeing and working with your patients, you're working with every single patient that that learner will touch in the future. It's a huge privilege and a wonderful opportunity, and I encourage you all to take it.
That's great. Mary?
I would say make sure you can take away something from the experience with that student. You never know, as a preceptor and a professional yourself, what you might be able to learn from someone else. So I always try to make sure that I can take something away from my experience with that student.
We hope you enjoyed and gained practical insights from listening into this discussion. Now that you've listened, pharmacists, physicians, and nurses can receive CE credit.